Hi, Allon.
Hi, Jill. How are you?
Good, thank you. So as predicted, we've got participants already joining, so they'll just be in the background.
Hi, Sanjay.
How are you doing?
I'm good. How are you?
Managed to finish the clinic?
Well, I've been operating all day, but yeah, it's good to be finished.
I know.
Yeah.
You're still at work, or?
What's that?
Are you back home or still?
No, I'll get rid of the vertebra. I'm at Ophthalmic Science London. I'm just in the.
Okay, right. Okay. Yeah.
I've got another meeting after this.
Is it?
Yeah. I need a holiday.
You know when you sign up for these, and I think during the lockdown we had a lot more time, and I think now things are much busier.
Yeah, totally.
Isn't it? Just rushing.
Hi, Mayank.
Oh, hi, Allon. How are you?
I'm good. How are you?
Yeah, not bad. Thank you. How shall I introduce you?
I don't mind. You can.
Working at Luton and.
You can just. I normally just use the Ophthalmic Consultants of London now. So that's. Yeah.
Fine. Because the cases are basically A&E based.
That's fine.
For the audience, but the majority of the audience are NHS based. So.
All right. We'll have to try and.
We can still answer them while working at.
Can I still do that stuff? I don't know.
Oh, you will be able to. They're a bit of reflective cases as well. So.
Great.
Yeah.
We've got 12 people on board so far, which is good.
Is it? Right. Okay.
7 attendees.
Fantastic.
I know Jonathan has gone for a cup of tea.
Okay.
You got a cup of tea. All good.
Got water here.
Mayank.
Yeah.
Oh no, there's people. See, I'm getting a cup of tea.
Yes. Sorry, I can't see you. Can I? Yes, I can.
People in. Yeah. Okay.
Sure.
People have joined, have they? Quite a few. Oh.
Hi, Philip.
Oh, 12 so far. Wow. We got some sound effects as well. Hello.
Is it better to keep it muted so that you don't get that?
Allon, you weren't there in the meeting 10 minutes ago, but basically you will be not muted, which means you can cut me off or you can interrupt me while asking questions or when I'm presenting the case.
Okay.
And please feel free to just jump in and give your opinion.
Sure, will do.
And we'll have 3 questions after each case. I have 7 cases, but I don't intend to show all 7.
Okay.
We'll only show 5, I think.
Fine.
Take questions.
Sorry about the feedback there, gentlemen. That was Professor Bloom calling for the link from his car on his way to France.
Is he on a ferry or?
No, he's in the car.
Is it Tesla?
Very possibly.
Yeah. Is he actually going to be a panel member then during his drive?
No, he usually is, but because he's travelling, he's not. So he's going to be an attendee.
But is he listening to us?
Yeah.
If he is listening, please ask him to jump in if he has any comments or opinion.
Who's so as an
Philip Bloom.
Mr. Bloom, Professor Bloom.
Yeah, he's on way en route to France, I think, in the car.
Good evening, Allon.
Hi, how are you, Paul?
I'm all right, mate.
I think you need more. You definitely need more awards and certificates. Yeah. You need to.
Some of them are my son's karate at 8 years old.
Perfect.
And I did go on eBay and get the rest.
That's fine. They look good.
It was one of the little things when lockdown started, my wife works at this desk and the wall behind didn't look very good. So we decided the first job we did in lockdown was we redecorated this room and stuck all those up.
If you're giving webinars, it's essential. Either that or lots of books that looks like you've read.
Yeah. Dostoevsky and
Yeah, exactly. War and Peace.
Right.
Hi, Jonathan.
Hi, Alan. How are you? Oh, you're high up, Alan.
Yeah, exactly. I'm heady heights.
Did you have to rush to get to join us? Were you busy?
It was fine. Oh, yeah, I mean, it was fine, but we finished in time. The team are very efficient, so it was finished up before 5:30, which is good.
Good.
Yeah.
Good. Okay. 25 people joined us so far.
Well, I was manning our eye casualty all day today.
Oh,
And
wow.
I was just praying that we didn't have some horrendonoma come in at 12:30.
In Edinburgh on the NHS, and also works at Laser Vision Scotland. To your bottom left is Mr. Paul Ursell, who again is very experienced anti-segment surgeon at Epsom and St. Helens Hospital, and you might have seen him on different webinars recently. And then we've got Mr. Jonathan Ross, who works at the same place as Mr. Sanjay Mantry at Golden Jubilee Hospital in Edinburgh and Laser Vision Scotland. We've got Mr. Saj Khan moderating the questions. I think there is a question, is there? Paul, you posting there?
Yeah, it started.
Who said hi to everybody?
Okay, hi. So as Jill alluded before, actually, we will have at least 5 cases. I've got 7, but we'll aim to do 5 cases. I will be interrupted by the panelists if they have any questions or if they have any opinions on the management, and then we'll go through the options of each cases with the different panelists. So without wasting any further time, I'm going to share my screen. And can you see my screen, guys?
Not yet.
Now, can you see my screen?
Yeah.
Yep.
Great. So first of all, I must thank all these interesting and complex patients I see on a day-to-day basis for this presentation, and my fellows and trainees for preparing this. These are disclosures which I have, which are not related to this presentation. The first case. So we've got this 93-year-old patient, grade 3 cataract in the right eye. The left eye had a vision of 6/9, so he's fine. We're only dealing with the right eye where the vision is count fingers, and he's listed for the cataract surgery. Axial length is about 23 millimeters in each eye, and the left eye is pseudophakic. The patient has got cardiovascular risk factors, so hypertension, angina, past history of embolism. Patient has got difficult spine, which means lying flat is difficult. Patient has got a gastroesophageal reflux disease, which means he cannot lie flat for longer. He's on warfarin, ethanol, and all of the medications, but the important bit is warfarin here. So the trainee starts the surgery as subtenon anesthesia because the trainee is very confident that they can do this complex case. But the subtenon anesthesia, the volume of the anesthetic injected is 3.5 mils, which is slightly higher than what I would normally use. And during the cataract surgery, when the last piece was coming out, the posterior capsule started bulging. The anterior chamber was shallowing. Halfway through the IA, the shallowing worsened to the extent that when the last piece of cortex was going to come out, the PC was almost touching the endothelium, so very shallow chamber. At this stage, the patient wasn't complaining of any pain. So to the panelist, what would you do at this stage?
Like, can I answer?
Yes.
So the first thing that you need to do is try and exclude reversible causes of this kind of scenario.
Yeah.
So although not common, it could be if the trainee's been operating for a long time that the bag on the drape is totally full of fluid, which is creating pressure around the eye. So if that's the case, I have one of the nurses use a 50 ml syringe and basically aspirate, make sure that the bag is empty, relieve any pressure on the speculum, make sure that the anesthesia is still working, the patient isn't actively squeezing their eyes. And if you've done all of those things around the eye to try and prevent that there's any pressure around the eye, then you have to look at potentially, is it a problem internally? With a normal red reflex, it's unlikely to be a suprachoroidal hemorrhage, but obviously it's something that's always in the back of your mind. I think what's more common than people realize and is somewhat underdiagnosed is something called posterior misdirection of irrigation fluid.
Yep.
And especially given that you found here during the IA, that's when the problem started to occur and then got worse and worse.
So it was the bag. I can say it wasn't the bag, and the reflex was pretty decent actually, but the booster capsule was touching the endothelium.
So it probably is posterior misdirection of irrigation fluid. Obviously, we're assuming the posterior capsule is intact and there's no vitreous loss like that. But posterior misdirection of irrigation fluid is a real nightmare to manage. I've only had it happen to me twice. Once I was a trainee, once as a consultant. People describe doing things like putting needles into the pars plana and trying to release fluid and things like that. But I honestly think that at this stage of the operation, when the cataract's out, the safest thing to do is probably to just stop operating. And you can either wait and see if it improves enough to safely put a lens in, or just leave the patient aphakic and then bring them back at some later date in order to put the lens in.
Excellent. Any comments from any of the panelists?
I think I'll go next. I think Allon has covered most of the things, which really most people can forget. One, external, internal, and you want to always keep at the back of the mind when you've got extra pressure to exclude suprachoroidal. And if you've got something like that, it's quite important to actually think, if you've got any iris prolapse and posterior bulging endothelium, though the red reflex is unchanged, you can get a suprachoroidal limit, which you actually, so your red reflex is good. However, when you actually see them with indirect later on, you will see a superior or inferior, very limited if you control it. So as Allon said, you probably want to actually try and see if you can put a lens in. But if everything is coming out and it's getting harder to do that, best is to either put a Myocol and put a stitch in, if depending on how the iris prolapse works. But you want to close it up. Use Damox. See the patient actually to make sure that there wasn't any suprachoroidal, and come back. I used to come back probably up to 4 weeks later, but actually I've had to do almost a week later with everything settled, and it's worked absolutely fine. So it all depends on how the eye settles down afterwards to do a second lens implant, whether it's first.
Thank you. Any other comments, Jonathan and Paul?
I would say this is for me one of the very rare occasions when you would act before you think. If you're convinced that there's a definite change in the vitreous pressure and that the tide is going against you, my approach to this would be to assume the worst and secure the AC before I then reassess the situation. So I would want to, probably in most cases, unless you've got a really well sealed incision, just get a single suture into the wound, make it tight, secure the wound, stabilize the AC, and then stop and think. I'd be inclined to agree with that, Allon, that the most common problem is misdirection of fluid towards the back of the eye, which is the better option in the sense that if you stop operating, the situation should stabilize because nothing further is happening. But if you've got a progressive suprachoroidal situation, then that will continue to worsen with you doing nothing. So, and you've removed the cataract and only got soft lens matter left over, so you can leave that in the eye without worrying about it. So your main objective here is to stabilize the situation, then stop and think, see how far you can reasonably reinflate the anterior chamber. And another thing you can do here is once you're at that point, you can then get an indirect and a 20 doctor into theatre and have a look at the back of the eye and see if you can see a darkening of a quadrant or a suprachoroidal, so that you can really be sure you know what the problem is. But in the occasional situations where I've had this arise, it has resulted in me doing exactly that, putting some cefuroxime in, and inevitably going back into the eye after a few weeks and finishing the job off.
Okay, so the common theme we had so far is to stop the procedure. If you can suture the wound, you can, but otherwise just come back later and assess the patient. Paul, anything to add on this?
No, I mean, I think that I'm more heading towards choroidal rather than misdirection in a 93-year-old on warfarin who's hypertensive and a difficult axis because it's kyphosis. So yeah, I think the thing that I would say is recognition. We're all trying to chug along and do the operation, and we've got other things in our mind, and it's realizing, okay, fine, we gotta. It's being aware that this is something that's not clever, and as John said, it's just get the suture in and then think about it afterwards. Because if this is a genuine choroidal, you wanna secure the AC. I also like the idea of putting some cefuroxime in, but there's also, having had a few of these over the years, it's so much better if you stop and think and then go back, and when your mind's cleared, because you'll suddenly start to get quite sweaty. And stopping and then maybe coming back next day or a few days later is so much, in the long run, a better thing to do, even though it's counterintuitive as to what we're trying to do, which is finish the op.
Yes.
And certainly in this situation, I wouldn't try putting a lens in, just stop and think.
Yeah. So we did the same thing as you guys suggested. We didn't put the lens in. We took the patient on the ward and did a B scan, and we found a small inferior suprachoroidal hemorrhage, as we all discussed. So we then referred this patient to VR team, and VR team said, well, best to wait until this hemorrhage settles, which took 4 weeks to settle down. And then we took the patient back to the theater, and this was the appearance. I don't know whether you can see the screen clearly, but basically what you see to your right is a temporal wound, and the iris is stuck in the wound. There is a lot of SLM, subincisional, which means subtemporal, and the anterior and posterior capsule is attached to each other. So if you have this scenario at 4 weeks, what are your priorities and what would you do? I don't know whether you can see near the temporal wound that there is a clear space here, which I'm showing with my cursor, which is probably a stretch of the zonules from the capsular bag. So how would you manage this now? Because the capsules are now fused together, and there is SLM there, and the iris is in the wound.
Mayank, before you ask people to carry on with that part, David Lockington has very sensibly asked for an opinion on how people would have put the iris prolapse back in that situation of the pressure being raised.
Well, I would not bother with the iris prolapse at this stage. I'll just close the case as we discussed. I don't know what the panelists think. Are you guys agreeing with that, or you would go and put the iris back?
Totally. I think closing the eye, whether it with or without iris prolapse, is the most important thing. However, you could go opposite to that incision if you had space. So let's say if you don't have any space, the best thing is to do nothing really, in terms of you want to close the eye and actually revisit it when the pressure is down, because you're trying to limit the suprachoroidal to a limited infrasuprachoroidal rather than anything else. But if there was a space, you could go opposite incision and do repair the or deal with the iris prolapse. But I agree with you. If it's totally bulging, touching the endothelium, the PC, there's no space, then I won't bother about the iris prolapse. So just close the eye.
I agree. I wouldn't go anywhere near the iris prolapse. This guy's on warfarin. He's 93. You start mucking around with that, it's just going to unravel in front of your eyes, and you're going to make a bad situation a lot worse.
Yeah. So, Paul, how would you manage this at this stage now? At 4 weeks, you've got fused capsules, a bit of vitreous seen under the temporal wound, and iris in the wound.
Okay, so I've done a few cataract patients who've had suprachoroidals. Actually, once it stops bleeding, it self-seals, and we've gone in next day and fixed them before.
Mm-hmm.
And I think my second case back after lockdown was somebody who had a suprachoroidal in the other eye, and now we need to do the cataract in the second eye, which is my second one after a 4 month break. Thanks, guys. So in this situation, you want to do as little as you need to, I think. He's 93, he's got good vision in the other eye. I would say you probably just want to try and get some form of sulcus lens in there. And if he has problems with that PCO, YAG it at a later date.
Would you not open the capsular bag?
Why?
Well, it's 4 weeks down the line. Everything is quiet and white.
He's already had a suprachoroidal. He's on warfarin. I would just be as minimally invasive as I could. You could open the bag. 4 weeks. The bag's shut at 6 weeks. You could definitely open that bag. You might be able to do a bit of IA. If it's not that inflamed, I can see you're about to do that, Mike, so I'll be careful what I'm saying. But I would just stick a sulcus lens in and YAG him if there's a problem with the PCO. So
we opened the bag, yes. And we also did the IA, as you mentioned. And I thought we should also put a capsular tension ring here, because I was not sure about the zonular integrity to the right. As you see, the capsular rex is slightly D-shaped there. So we put a ring in. just to stabilize the bag, and then put the lens in. And then we didn't bother with the iris at all. We kept the iris in the wound as it is and used the myocol to shrink the pupil. Just checked the leak with the fluorescein. There was no leak. And we left the patient with the peak pupil. How would you have managed this case differently? Allon?
I mean, it may be worth liaising with the physicians about the warfarin. You know, patient doesn't necessarily need to be on warfarin for the procedure. So there are ways of kind of using shorter acting anticoagulants that you could potentially stop for a day before surgery, and then he restarts after, and then recommences warfarin after that. So, you know, if I at the time that I knew I was going to revisit it, I would liaise with the physicians and see if there's a way of removing what was probably his biggest risk factor for having the suprachoroidal. With respect to the iris, it depends how long it's been from the time of surgery. So
4 weeks.
How long?
4 weeks.
Yeah, I mean, I don't think that you have a lot to lose, but well, first of all, is he symptomatic of glare or anything like that? If the answer is no, you could probably leave it. But if there is glare, and this is it's in the palpal aperture, isn't it here? So it's potentially a case that could suffer from glare. It's not going to be covered by his lids. You can go in opposite with a small, like a 1 millimeter incision, and then use coaxial micrograspers like the MST micrograspers, and see if you can pull the iris free of the wound. But often it won't come, and you don't really want to be doing anything forceful in someone that's already had a bleeding problem inside his uveal tissue before. So I'd be very gentle and very cautious if I was going to do anything at all. But certainly leaving it alone is perfectly acceptable as well. Yeah.
Jonathan, Sanjay, any other comments?
I'd just say when you take the patient back to the theatre to finish the job off, just optimize your variables to get the best chance of success. So I mean, you've got a very elderly patient, so you be careful about the kidney function, but I'd probably give some Diamox pre-op. Make sure the blood pressure is as well controlled as I can. Just do everything I can to increase the chances of the eye being relatively soft when you go in. In my experience of a few of these cases, the eye is actually quite well behaved when you come back to it. I would viscodissect out the bag and put a lens in the bag unless I had reason to believe that the zonules were weak.
Yeah.
With regards to the iris, again, I think fighting the iris when the eye is hot and angry is a bad idea. Your priority at the outset is to have a stabilized eye and hopefully be able to maintain a formed anterior chamber. The iris will naturally follow a gradient downhill for pressure. So if you've got a high pressure AC, you're definitely going to potentially make matters worse by trying to get it back in at the outset. But if you go back to a soft eye, it should pop back in relatively easily, even if it's not in that good a shape.
And this is an example of another case, a similar one, where we went back 2 weeks afterwards and replaced the iris. In this case, we were able to place the lens before the pressure spiked up. So we were pseudophakic when we went back inside and replaced the iris back in place. So you can do that. And I think we will finish the case one here. We can take the 3 questions from the audience now and move on to the next case. Any questions, Saj?
So there was one question you've already answered. The other question that's been asked is, although you partly answered this anyway, would you consider asking the patient to wait after closure, do an examination, and if you find that there's no suprachoroidal, bringing the patient in at the end of the list, put the IOL on the same day?
Would you do it the same day? I wouldn't. Would you guys do it on the same day?
No, I think the patient is already anxious about it. The patient is on warfarin, the patient is 92. And, I think if the pressure, if anything, it'll be asking for trouble, actually. And I know there's that surgeon behind you saying, oh, I need to, by the end of the day, I've put a lens in, it's the end of the list. But I think from a patient's point of view, I think the best option is to come back 2 to 4 weeks later when the eye's soft.
Shall we move on to case number 2 now, Saj?
Seeing as Paul volunteered to answer that question, I was quite interested to see if you had anything different to add to that.
I was going to completely agree with Sanjay there. This guy, poor old boy, he's had a tough time. I think a chat with him and bring him back later on would be a very wise move.
Yeah.
I think poor old surgeon as well. I think I'd give the surgeon a break for the rest of the day.
Yeah. Okay, case number 2. So this is a 60-year-old patient with dementia and Down syndrome, referred from the optician with history of significant reduction of vision in both eyes. The patient is bumping into things at the care home where she lives. Slit lamp examination is not possible at all. So in other words, the optician has basically passed on the buck to us to deal with the patient in the NHS cataract clinic because they think the patient might have a cataract. The patient has history of atopy, the skin has got eczema, and has got multiple medical issues and is a high-risk GA. How would you manage this patient? You haven't examined this patient because it's very difficult to examine this patient on slit lamp.
You want me to go first?
Yeah.
So this is probably common in most of NHS unit running a corner service. I think you would probably, somebody like that, the reason they get referred is their quality of life, or they are is affecting them. If you can't examine them altogether, the best thing to do is almost a whole list for it, or a morning or an afternoon list. No rushing, nothing at all. Get the best anesthetist that you know, not the anesthetist who cancels everything, and try and plan it in such a way that you can do a EUA with a biometry and keratometry on the table, and possible consenting in such a way with the family that either you will not do anything, or you will do one eye, or you'll do both eyes, depending on what your examination and your anesthetic finding is. But exceptionally, I would say most of these end up being some 9 out of 10 times, because of coexisting keratoconus, which has not been looked into as well, and with atopy and Down syndrome, the keratometry, you sometimes end up being a 22 diopter lens. But you would do as much as possible if you can get all the measurements. And I think my approach would be going in a graded fashion and consenting for all the issues, but hoping to come out with bilateral cataract surgery if we can.
So Sanjay, we took the patient, as you said, to the theatre, and booked the whole session for it after going through the IMCA process and getting all the consent issues sorted out. This is what we find. The right eye is thicical now, as you see in the picture here, and the left eye has got a white mature cataract with a very steep and very advanced keratoconus and corneal thinning. What would you do next?
So essentially only eye. I don't think you have a choice here. I think though it's a mature cataract, but it may be very soft, and I think you just have to try. Worst case scenario is to leave them aphakic. But I think with that advanced keratoconus, but depending on how the cataract looks, if it's I would definitely attempt to.
Biometry showed -30 diopter intraocular lens.
Right. I think I wouldn't trust keratometry with this cone.
Yeah. Anybody else on the panel wants to comment on this?
Yeah, I mean, you've got a tricky situation. I mean, your best interest meeting with the family and the IMCA would have hopefully covered all your scenarios.
Yes.
You're trying to ascertain what level of functional visual acuity this individual had a few years ago. So, were they self-caring? Were they feeding themselves? Did they play games? Where do they get to? People with Down syndrome, all learning disability patients, people with learning disabilities rather, will get basically they age quicker, so they'll get hypertension, dementia, everything else at an earlier stage, which is what you've got here. And you want to try and make them have a better quality of life after your surgical intervention.
So what would you do in terms of lens, intraocular lens?
I'd definitely put an intraocular lens in. I think that your chance of getting PCO have reduced by doing that. And that would basically, if they get PCO, you'd have to give them another anesthetic. So you've got to put a lens in. You're looking at someone here who probably only got navigational vision at the best of times back in the day. So just putting a 21 lens, 22 lens in is probably going to be better than nothing. And
But
I think
the picture is -30
yeah, that's just I would ignore that.
from the corners. Yeah. Okay, Alan, Jonathan, any comments?
Yeah, I mean, what I normally do is speak to the relatives and carers about whether they feel that the patient's level of vision now is insufficient for them to be able to do things that they like to do, because how someone functioned 5 years ago who now has dementia is not really a meaningful assessment of what they actually need to do. So if this is someone that just spends all of their time in bed and doesn't do anything, then you might ask yourself what the necessity for surgery at all is. However, if they like to watch TV, look at magazines, you know, and they're mobile and they're navigating, and they're no longer able to do those things that they like to do, then you do need to intervene. Mm-hmm. And you know, the biometry, you know, that kind of level, I don't think I would just put in a 20 diopter lens. I'd put in the lowest power I have available. So maybe
we had 0 on the shelf, so we put a 0 diopter Rayner lens.
0
in the bag.
0 in, and then, you know, the only way they would enjoy reasonable vision here would be would be with a contact lens, which isn't going to be an option in a patient like this. The other thing to do also while they're under anaesthesia is to have a look with an indirect and look at the fundus and check that's okay, because the other eyes become physical, and obviously to check that the pressure is normal. So.
And the reason for phthisis was she keeps on rubbing the eye, and that's why she's got keratoconus as well. So based on that information, would you do anything different now after you place the lens inside the bag?
Put a stitch in.
Yeah.
Dissolvable stitch. Yeah, I put a dissolvable stitch in, and then you just speak to the carers about the necessity for shields, but it's a real nightmare for them. You know, it's difficult. These patients want to take their shields off.
So we did the Weichel sutures, as you say, Allon, and we also did a partial tarsorrhaphy because of the issue of rubbing and issues with the shield and so forth.
Yeah.
Allon, if I could just jump in there, there's just one thing I'd like to add is that just because they have got dementia and they're not doing anything, it may be that this person doesn't function and is bedbound or has all the compromises to their daily activities because of their bad vision.
Yeah.
Mm-hmm. I think we should actively try to improve vision in people with dementia as much as possible. There's lots of evidence to show that dementia, people with dementia have less cataract surgery compared to the general public. And I think it's important that we intervene. We're not aggressive, but we give people as much of an opportunity to have a cataract operation to improve their quality of life as we would to anybody else. And you know, there's a lot of evidence that we're failing as a community to do that. So I would be quite keen to take a cataract out in people like that, just as long as the downsides are managed as much as possible.
Yeah, great. Any other comments?
I think I agree with everything there. I mean, we need to make a case for intervention here because this is quite a high risk situation. We've got one eye. Yeah. I think a 60-year-old Down syndrome patient probably doesn't have a very long life expectancy. So who's pushing for the surgery? How many, you know, there's not going to be a great deal of years gain on the back of it. And if there's a significant complication, then it may have been obviously the wrong thing to do. You said, was it -30 or -20 lens that was the
-30, 30.
Okay, so I probably put in a. I think you can very easily get a -10 lens now with also with a -10 sulfur.
But remember, you don't have time to order the lens.
You don't have time. You've got to decide.
You're on the table, and you can't come back with a.
Right. Okay. Well, if I had, I mean, you can get banks going down to -10. I put in the lowest lens I could get hold of. The rubbing situation concerns me. This might be a time when I would go for a bit of a scleral tunnel for my access to the inside of the eye. I like the idea of a tarsorrhaphy, but I want the case to be made for intervening at all. But then, as Paul said, dementia in this situation is probably intertwined with really poor function, and actually improving function can get a surprising improvement in cognitive function postoperatively as well. So there's a lot of factors to be weighed up here, and one would assume that the family would be heavily involved in any decision.
Yeah, I agree. Any other comments?
And add to that, I think, to be honest, if you've got a phthisis eye, you've only examined, actually, you know, in retrospect, once you've done EUA, you kind of know you've got a white cataract with such an advanced keratoconus. You're talking of perception of light or big hand movement as the vision with a white cataract. So I think there is enough justification once you've done the EUA to actually intervene. So I think it was a very good management.
Yeah. Saj, any questions from the audience?
There's not so much questions as to people just agreeing with the fact that you've got to consider what impact this has on quality of life, the higher risk of endophthalmitis, and obviously post-op concerns about the eye rubbing. The other question has been asked about if a patient does get endophthalmitis, obviously having a tarsorrhaphy makes it a harder thing to address. And I guess it equally makes it a little bit harder to monitor the eye if you can't get close to the patient in the first place.
Yeah, completely agree. Then we'll have to open the tarsorrhaphy and do the needful at this stage. Great. So let's jump on to the third case then, if there are no other questions. So now we've got a 64-year-old patient who had a penetrating keratoplasty in 2017. Sutures were removed in 2019. The patient has developed a cataract, and the patient has 14.9 diopters of corneal astigmatism. They've tried RGPCLs and scleral lenses, but they don't improve the vision. So what are your options? So corneal astigmatism is very high. A patient has got a cataract with a previous transplant. How do you manage this patient?
Okay, because that 14.9 is my natural, all my grafts, I'll go in first.
Yeah.
No, I think typically in this one, you know, you've got cataract, you've got 14.9 diopter astigmatism. There, I mean, without saying about any particular company, but there are, I would definitely in this one try and think about doing cataract surgery with a toric lens implant. And you know, I've done up to 18 diopters that Rayner has actually made bespoke for the patient, and reduced it to less than 1.5, which is actually. So I think there is some on the Pentacam you can see. Majority of it is regular, though even if it's irregular on the nasal side, I still think it'll correct most of it. So my personal,
you will go for a toric lens in a patient with previous transplant. This is a 64-year-old, so youngish. So the patient's transplant may reject in 10 years' time.
Yeah.
Yeah. Great. Any other comments from the panel?
I think that despite the fact that toric lenses are, you know, the technology continues to evolve and that they can do a lot of wonderful things, it still remains the case that in an ideal world, the best way to treat corneal astigmatism is on the cornea. And although you're not going to be able to treat 15 diopters of astigmatism on the cornea, there has been a nice study that I think Frank Larkin and Mark Wilkins published over a decade ago. And it does show you that the more you need to achieve, the more you can achieve with astigmatic keratotomies in patients that have had penetrating keratoplasties or deep anterior lamellar keratoplasties. So sometimes you can think, well, 15 diopters, that's not going to be something we can overcome with an astigmatic keratotomy, but you can be quite pleasantly surprised. And I find that patients who have had grafts more recently tend to respond better. So the ones where the PK is 20 or 25 years old tend to be very unpredictable if you're trying to do corneal work with them. But in someone that's had a relatively fresh penetrating keratoplasty, and that's quite regular looking astigmatism to me, I would definitely do an astigmatic keratotomy first and expect to possibly halve that amount of astigmatism. And then at that point, when healing is complete, then I would consider a toric lens.
So that's a very good point, Allon, actually. Do you notice that there is slight asymmetry of the regular astigmatism there? And do you did it ever cross your mind that the donor may have keratoconus here?
Yeah, but you can still get an effect by putting an astigmatic keratotomy into the.
No. But you probably had a kind of thinking that this donor might be keratoconic. You can still get away with the astigmatic keratotomy. That's fine. Now I'm going to show you the picture of the eye. This is the picture of the eye. Do you think the reason why this patient's got 15 diopters of astigmatism now, and that too very regular?
There's still stitches there.
No, I'm moving my cursor on that. See the superior cornea here, which is the bottom part of the picture. What is that? That's a limbus. So this transplant, when it was refined, was to capture the limbus on one side. And because the shape of the cornea now, we have got a pseudo keratoconic appearance of the donor and a high astigmatism. You see that white part at the bottom there?
It could be arcus though.
No, arcus would be symmetrical. This is the limbus and the scleral part of it. So anyway, yeah.
No, arcus could look like that actually. And you know, when you said you could actually have an eccentric refine where you actually could have the lower bit of the keratoconus left when the PK was done. The posterior slippage of the posterior edge of the graft, which Harminder had done a lot of work on. I mean, there could be a variety of causes for that, actually. You know.
So I agree with Sanjay. I'll put a toric lens in and deal with the rejection later on if that happens down the line. But with 14 diopters, Rayner doesn't do up to 14, so I had to do a piggyback Rayner. So I did toric and toric, which means one toric in the back and then sulcoflex toric in the sulcus. Now, you can argue that that is not the best combination because sulcoflex will spin later on. But then apart from Allon's idea of doing AKs, there's no other option in this case. Or is there?
Well, for the toric add-on lens, I would be inclined to use one of the Medicontour add-ons rather than the sulcoflex because it's a lot more rotationally stable.
Because it's got 4 haptics like a Mickey Mouse.
Yeah, exactly.
I don't have any experience with those. Do you think they're more stable than?
They're supposed to be much more rotationally stable, and actually they're just as easy to use. Yeah.
So this is in the back toric, and then we place a sulcoflex, which is in the same axis. And
what was this gentleman's vision in his other eye?
The other eye was 612, not bad at all.
And why did he have corneal graft in the first place?
I think this patient had some sort of herpetic scarring.
Okay. So if he had good vision in the other eye, I'd be inclined to go with Alan's preference and try to do something to that graft to make it a bit less toric. And then once you've done that, work out how you can approach the cataract. You've got no urgency if you've got good vision in the other eye.
Yeah, I agree. Yeah.
And if you've got a toric IOL, a toric sulcus lens, and a toric cornea, that's going to end up changing at some stage. And then he'd have 3 toric lenses in a refractive system, which we could quite give a lot of higher order aberrations.
Another problem that I've seen in a lot of patients like this, when people try and achieve what may not be achievable with a lens, is that if this patient does require a rigid gas permeable contact lens or a scleral contact lens for good vision, because there is going to be an element of corneal astigmatism or irregular corneal astigmatism contributing to the poor vision, then you unmask all of the intraocular astigmatism that you were using to correct in their vision. So one option after doing the astigmatic keratotomies is to put a monofocal, because you can't assess the vision in the context of a dense cataract. So you could put a monofocal intraocular lens into the bag. You could then refract them to check what their potential for vision is and get an idea of, is regular astigmatism their main problem, and would it be correctable with a intraocular or even potential even a corneal refractive procedure. And you then have the option of doing PRK if the astigmatism is less than 6 diopters, or you could do a sulcoflex or a Medicontour or an ICL even to correct the astigmatism in the sulcus. And then what you've got is that you've got a monofocal in the bag, you've got a toric in the sulcus, and if they were to develop rejection or need to have the PK redone, you could just take that out at that time point. And you've also, by doing it in that way, you've also checked them with respect to their potential of vision, because if you felt that they did actually need a rigid gas permeable contact lens to see well, i.e. it didn't correct well with a spectacle type refraction, then you wouldn't use a toric lens at all. You would just let them have an RGP and stick them with a monofocal in the bag.
Alan, what's your experience with the PRK in these eyes? My experience is that they are slightly unpredictable.
Yeah, I agree. I agree. It's definitely not my first line.
Yeah. Great.
I suppose the other thing to throw into that, Alan, is that did you say it was a herpetic problem in the first place?
Yeah.
So I guess the thing I'd be thinking in that context was actually, although there are a number of ways of achieving the best optical system here, I'd probably want to plan it so that I did the least interventions possible.
On the cornea?
Anywhere.
Yeah. Okay, any other comments?
Right, Mike, I know you guys have touched on bits of these, but I think as teaching points, it's quite nice if somebody would like to summarize. The question here is, does asymmetry or symmetrical astigmatism in the patient's cornea influence the choice of procedure? Which you kind of answered, but if you want to give a succinct answer to that.
Alan, do you want to do that?
Yeah. It's difficult to make a total quantitative assessment, like on the topography, for example. What you end up seeing in all of these patients is there is always an element of irregularity or asymmetry. So you're trying to make a qualitative assessment on, is there an element of regularity to it? And it is mostly regular. You never see a perfect bow tie. Well, not never, but you almost never see a perfect bow tie in a patient that's had a PK or DALK. There's always a little bit of irregularity somewhere, which is why I like the idea of doing a contact lens over refraction or a refraction without a contact lens, but you don't have the option of doing that when the cataract's there. So the only way to know in this case is to remove the cataract and then evaluate for it afterwards. Otherwise, you're just deciding on what you think is likely to work. So that's why I suggested astigmatic keratotomy, because that's likely to give you some effect, but you then don't know at that time point. If you then put a toric in the bag, you could end up with a 6/6 unaided vision and the patient's over the moon, or you could end up with a patient that's 6/18 because they still have 3 lines worth of irregularity there that requires a rigid gas permeable contact lens, and they then need to wear glasses over it to counteract what's the touricity in the bag. So they are difficult cases to manage these. There's no right and wrong, but I think trying to have a stepwise approach where you don't try and do everything all at once is how I normally do it, which requires many visits. It burdens the National Health Service system. There are arguments against it, and just going for a straight, toric IOL in the bag and that it may work it does have some justification, but it's not how I do things.
Yeah, we avoided corneal procedures in this patient because of the previous history of herpes, but yeah, you're right, you can offer that. Any other questions, Saj?
Would anyone use a pinhole IOL to correct the residual refractive error?
That's a good question. No, I haven't, but I'm planning to in future because I've heard a lot about that. Anybody else has used that?
Yeah.
I've used it in a couple of PK patients, mostly in radial keratotomy patients. When the steepness is mostly central, I quite like it. But when there's some eccentric steepness, so when there's significant asymmetry, as you would see, for example, in keratoconus, I am concerned about it because the size of the aperture, I think, is something like 1.6 millimeters, and there are assumptions about where the nodal point of the eye would be, which are assumed that it would be the same in a pathological eye as it is in a normal eye, not necessarily the case. So if the nodal point is eccentric, which I think you might assume would be reasonable in a severe or extreme keratoconus or significant irregularity in PK, you have to be a little bit careful. So it's a consideration, but also with caution. Okay,
great. Any other questions, Saj?
There are more general questions coming through, but they're not specific to that case.
Okay. So we can do that at the end of the webinar.
Absolutely, if we've got time.
Sure. Okay, so the fourth case now. 84-year-old now this time, type 2 diabetic, without any retinopathy. This is important. So the patient doesn't have any retinopathy. Suspected Sjogren's syndrome with dry eyes on regular lubricating drops. The picture of the dry eye is similar to the picture shown here in both eyes. The patient has cataract, which is worse in the right eye compared to left eye. What precautions you will take pre and post-op in these patients? Hello. Yeah.
All right, I'll crack on. Have a go at this. So your main concern is how much of their visual morbidity is due to the corneal pathology, and how much is due to the cataract. So
cataract is fairly advanced, so it is established that it's because of cataract mainly.
So it's going to be a bit of both, but it's going to be mainly cataract. that amount of SPK is going to really mess up the barmetry, particularly the Ks.
Yeah.
So you want to really go to town and try and maximize the blepharitis dry eye treatment prior to getting barmetry.
Yeah.
So you need to really find out what modifiable factors you got in there. Are they? Can you optimize their droplet regime? Are they on omega-3? Maybe you want to put plugs in. Are they using wipes, etc., etc. So you really want to get as intensively into their blepharitis regime as you can. And then when it gets good, because it's never going to get better, but when it gets good, that's when you want to do your biometry.
So she had the same thing. So she had biometries done 3 times on 3 different occasions, and surgeon X did the surgery on the right eye, which was worse eye. Post-operatively, the surgeon prescribed Stubradex 4 times a day, tapering for over 4 weeks. Vision post-op was 6/6 with the lubricating drops. Patient was happy, and so was listed for the second eye. Would you do the same to the second eye now?
Well, if you got the biometry for the first one, you've got the biometry. So one thing I would say is I would be very cautious about doing a temporal corneal incision on someone like this. Diabetics with bad blepharitis and dry eyes, you may well have an awful lot of neuropathy in their cornea. And if you do a temporal incision, you can often cut the corneal nerves. And I've seen a lot of patients who get really grim worsening of their dry eye symptoms because of the temporal corneal incisions. You get it with superior ones, but try to avoid a temporal incision in these guys.
Yeah, that's a good point. But given the patient was diabetic, would you have a tendency to give Acula or Nevanac or some sort of Bromfenac to these patients as precaution to prevent cystoid macular edema?
Yeah, okay. So most of us are using non-steroidals in patients with, well, combined non-steroidals and steroidals in patients who are high risk for cystoid. So you'd be thinking about that in these situations. I haven't published it yet, but I've got some data that shows that actually subcon steroids might be a good idea. And most of us have gone away from that because we've gone to topical because it's just, it's hard work and they don't like it. But we've got some data showing that subcon steroids is as effective in preventing CME as non-steroidals. And if you've got a diabetic with a bad ocular surface, you might want to avoid that, and therefore give a subcon steroid might be a better option than using non-steroidal drops.
Okay, so the second eye was done by Surgeon Y, who was a medical retina consultant or surgeon, and post-operatively they gave Tubradex as well as Acula to prevent cystoid macular edema because the patient was diabetic. And you just answered the question, you would probably not prescribe that, would you, Paul?
I would. We stopped using Acula about 5 or 6 years ago, and we changed to Bromfenac simply because of it's just grim. And anybody, I don't know, we got 111 people on the thing. Has anybody ever had Acula in their own eyes? It's really grim.
It stings.
It stings like hell. 4 times a day when you're 84 and you've already got surface disease, it's not pretty. So no, I wouldn't.
Any other comments from the panel? Would you prescribe Acula in this patient with Tubradex?
I think one of the arguments for giving Acula is actually the cost, isn't it? It's about something like £3 a bottle compared to.
So if the cost was not the factor, would you still give Acula to this patient?
No, I wouldn't. I would personally give it. What I might do differently is, and you didn't mention how long after the first eye, the second eye was done.
About 2 years down the line.
2 years. Oh, that's fine then. Yeah. Okay, sure. No, that sounds fine.
Okay. Allon, Sanjay?
I really don't like Tubradex anyway. I find that the aminoglycoside or the antibiotic component of it, there is often about 10% of patients seem to have some kind of degree of allergy or toxicity to it. So you'd give
preservative-free, I guess.
Pardon?
You'll give preservative-free minims to this patient.
Yeah, I mean they've got Sjogren's syndrome, so I would give minims preservative-free, either a fluoroquinolone or even chloramphenicol, and then dexamethasone and then as far as Acula goes, I use in private practice I use Yerox. In the NHS we just don't find it practical. Because I think patients need a really thorough pre and post-operative evaluation, because if you give it to someone with good going ocular surface disease, it makes their cornea neurotrophic and they can melt and perforate, and I've seen that before. So I wouldn't treat this patient.
So you were spot on, Allon, actually there. So this patient received this treatment, and on the 5th day, the patient pitches up in the casualty with vision of hand movements in the left eye. And this was a picture. This is a real patient we had at Brighton, basically. And this was the OCT of that patient. This is what we did to the patient, which is gluing. And when we glued the patient, we followed the patient up for a while, and the patient developed keratitis because of ocular surface problems, hypopyon, and suspected endophthalmitis. We then did a vitreous strap, which was negative, obviously, and we treated the patient with intravenous, oral, and topical antibiotics. Patient improved, but developed corneal melt around the perforation site. Now, what would you do next? Any suggestions? Hello?
I hate dealing with melts. They are just grim.
So basically, we did a tectonic PK. The PK went well for 3 months. But then the PK started melting inferiorly because of Sjogren's syndrome. The scrape was negative, no infection. And what would you do now?
Tarsorrhaphy as well to help it along?
Great. This is what we did. And now the patient's left like this. We have no other option. Patient's elderly, doesn't want any further anesthesia. And we have got no choice to give eyesight to the left eye. So we have left it like this. Any other suggestion to improve this eyesight in the left eye?
No, I think you've done you've intervened in the cornea. You've stopped the problem. But you had a domino effect from the original melt and the infection, and in an elderly diabetic neuropathic cornea, you're always you're chasing smoke, trying to catch that.
So the take-home message is Acula can lead to all these problems that Allon mentioned, and they can be really serious. So I do not give any prophylaxis to any diabetic patients anymore until there is an evidence that the patients had CMO before in the same eye. Would you normally give prophylaxis to all your patients, diabetic patients?
Yeah, we're doing. It's part of our protocol. I mean, we made an economic argument from changing from Acular to more expensive medication simply because of the number of times that we were having phone calls and attendance in our A&E. And we just estimated we could cut that by a significant percentage, and the financial savings would be recouped that way.
Okay. Any other questions or comments, Saj, from audience or from panelists?
Yeah, well, question from me to you, Mayank. When you did the tectonic PK, did you do an AMT as well?
Not at the time of the tectonic PK, because it went well for 3 months.
Right. Okay. And then in terms of your question about anything more you could do here, suggestion has been, would you want to involve rheumatology?
Yeah, they're already on board, actually. They are dealing with the systemic immunosuppression and all the stuff. Right. But in terms of improving the eyesight, we have hit a brick wall here. We can't go further.
I have to say, I agree with Paul as well in terms of I changed my practice years ago based on how often Acular patients call back or come in with issues. So.
Okay. Shall we move on to the 5th case then?
Just as your timekeeper, Mayank, just it's 2 minutes to 7, so you know where we are.
Yeah, this is a short one. We won't go to the 6th one. This is the last one. So there are 2 pictures here. Panelists, what can you see here? The patient to your left has got a history of 3 weeks old of pain and photophobia, and the right picture is of a patient who has history of pain and photophobia for 2 days.
Hydrops.
Yeah, great, fantastic. So there is a chronic hydrops to the left and an acute hydrops to the right. How do you manage that?
I think the traditional management would be, pain relief. People will, depending on if there's epithelial defect or not, you give red forte, dilating drops. But more and more, because there's a desmoid rupture, there has been recent success with doing a paracentesis and putting an air bubble. And specifically with all our endothelial keratoplasties, we've become quite good with air bubble management.
Yeah.
I presume your picture on the left is the one which is, or the right, I must say, 2-day-old. So yeah, I mean, you could either do a combination of just managing their symptom and waiting for that to settle down, or into
Couple AC. Yeah, that's a good idea. Alan, Jonathan, Paul, anything else?
There was a paper published recently. I mean, it's not something that I've ever done or that I would consider, but there was a paper published recently suggesting that you do a small localized DMEC in these patients because they're missing endothelial function there, and you can actually replace the endothelium in that area, resolve the scar more quickly, and they don't end up with the other complications associated with hydrops like vascularization and then further, future graft rejection when they need a penetrating or a DAO.
Yeah, I think that paper is published by the Southampton group recently. You're right. A small tectonic DSEC. Okay, so this is what we did. This is what we used to do, which is what Sanjay described, injecting air bubble in the AC. And it does work really well. As you can see here, this cloudy cornea clears up. But the problem is you have to keep the patient on the ward and do this procedure almost every day until you have the desmates stuck to the stroma there. But as you can see here, it does clear reasonably well. But because of logistical difficulty, we have moved over to suturing the desmates. All we do is just put crisscross sutures across the torn desmates, and this is the picture we get 6 months down the line. And this is the improvement we get with OCT. And this is also published in the past. You can either do a tectonic DSEC or you can suture the desmates. And you get a beautiful resolution like this on the OCT. So any comments or any other suggestions on managing these patients apart from these plans? Nope. Saj, any questions from the audience?
Yep. So question, why not use 20% SF6 rather than air?
Well, yeah, we have used that, but the downside is these patients are faking. You will end up with a cataract. And you have to guess them at least 2 or 3 times in the ward. You don't want to give them a cataract at a very young age, so best to avoid SF6. Use air if you can.
How deep did you go with your corneal sutures?
How deep? Full thickness, through and through.
And follow-on question to that is, so when did you remove them?
Depends on when you get the OCT clearance of attachment of the desmates. So it may be 4 months, 6 months, 2 months, 3 months, based on the tear and the extent.
Mike, do you worry about the knots when you're rotating them through?
No, I bury the knots in the stroma. I don't go with the knots inside the anterior chamber.
Okay.
Great. So I think we will not go to case number 6, as it's already 7 past 7. So we'll hand over to Saj to ask questions.
Literally, I mean, you've answered most of them as you've gone along. Okay, so...
Do you want to do one more case then?
No. You haven't got that much time. Paul, question for you. Which steroid do you give subconjunctivally to prevent CMO in your diabetic patients?
We just use betamethasone, which is our standard one, the one that's been used for years and years and years. We just looked at, there was the pre-med study done by Rudy Neutz, was looking at CMO, and one of their treatment arms had a subcon steroid, and they had very little CME in that group, even though it wasn't significant. It was obviously there was no CME in that group. So I asked my trainee to go back and look at our Medisoft database, and we had, just by coincidence, some surgeons in our department still using subcon steroids, and some weren't. And the incidence of cystoid seemed to be much less, particularly in diabetic patients who are having a subcon steroid. We haven't fully gone through the stats, I haven't published it yet, but it certainly has made me think long and hard about, in people with a risk factor for cystoid, whether we should be going back because we stopped doing it because of topical anesthesia for subcon steroids.
I think Allon's putting his hand up to make a comment there somewhere, but I have to say that I have still continued doing subcon steroids despite being predominantly topical. And I think, generally most patients tolerate it fine as long as you don't inject too fast.
Yeah, I'm learning that.
Okay, so other questions. On the case where we were discussing the keratoconus case,
Yeah.
where we touched on using a pinhole lens. Would anybody consider doing a pinhole pupilloplasty in that situation?
Pinhole pupilloplasty. No, I won't.
I think you've got a, this was the patient who was Down syndrome dementia with advanced keratoconus in their only eye, with a cataract. I think your best bet there is take the cataract out, get a lens in, and then just call it a day. I think heroics in that situation, an only eye in a patient like that would possibly be quite complicated.
Yeah. Does anybody, so another question about steroids again. Does anyone feel that intracameral triamcinolone would be better than giving subconj steroid?
Intracameral triamcinolone better than subconj.
I don't think intracameral triamcinolone has been, I mean, it's all off-label. That's the other thing. This is a public forum. This is all off-label. So you have to be very careful about that. I think people are moving away from triamcinolone because of the sort of endophthalmitis issues that we've been having, certainly in the vitreous, and that's why we're not using that so much anymore. I think that the glaucoma surgeons give intracameral steroids when they were doing MIGS. I think there is an argument for looking to see whether we should be giving intracameral steroids as well as intracameral antibiotics, like we give steroid and antibiotic drops after surgery. I don't think anybody's done it yet. But it's an hard thing to think about.
Okay.
Unless there's a PC rupture, I don't use intracameral steroids.
Sorry, say that again, Mike?
Unless there is a PC tear and vitreous loss, I don't use Kenalog intracameral.
Yeah.
Yeah.
Although I thought you said antibiotics for a minute, and I know that's not your practice.
Kenalog.
Mayank, the question directly for you here. Somebody's asking, they've got a patient with high drops with a tight DM vertical scroll. Do you think suturing would work in that case?
It would actually, but you have to go inside the AC with a spatula and flatten the roll first, like you do with the DMAC, and then suture. It might be tricky. Or you can use your own needle tip as you go along to flatten the scroll, and you might have to take multiple sutures as you flatten it.
Which kind of answers the other question of whether there's a role for compression sutures in high drops, which is effectively what you just described, haven't you?
Yeah.
Okay. And I suspect Paul has gone anonymous because somebody's asking if we can go to the bar now. So I'd blame that on Paul.
Not me.
And I think most of these are repeat questions, really. Anyone giving post-op Nevanac to diabetics instead of Acular?
Not me. Are you guys on the panel?
We're not, but I think Nevanac is the one that's got the license. So I think we have to be careful about licensed and unlicensed medications in this setting.
Yeah, if you are going to give a non-steroidal in that context, it probably should be Nevanac.
Yeah.
Okay.
And Mayank, you've got a question for somebody who wants to stay on just for a private case with you, who wants to know about what case 6 was going to be about. But I'm going to leave you the extra time to do that in your own time.
Okay.
Well moderated, Saj.
I think now is your time to wind up, Mike.
Okay, sure, great. If there are no other questions, well, first of all, thanks to all the panelists for sharing their views and opinions. I think we all learned a lot in this session. At least I did. And I now know that there are several ways to skin a cat. So thank you so much for your time this evening. A great and a big thank you to Ted and team. Actually, Ted, I don't know whether you're there, but thank you so much for sponsoring this webinar. It's a great gesture, and UKISCRS only survives on these kind of sponsorships. So we are having a series of webinars throughout 2020 and 2021. The next one will be 2 weeks from now, and it's a YOP organized webinar. YOP is a Young Ophthalmic Practitioners, but it's a UKISCRS webinar. The webinar is on AI in ophthalmology, which is artificial intelligence in ophthalmology. And we're going to talk about the big data. We're going to talk about the OCTs. We're going to talk about the biometries, the new formulas, and the new machines coming in, and implications of changes in our practice with these new techniques. So stay tuned, and we hope to see you all in 2 weeks' time for that new webinar. Thank you so much, everyone.
Thanks a lot, guys.
Thank you, Mayank. Thank you to the panel.
Thank you.
Good
Bye.
night, everybody.